Arteriovenous malformation of the colon evaluated using hemodynamic parameters in color Doppler endoscopic ultrasonography. These are disclosures. Arteriovenous malformation (AVMs) are uncommon vascular regions of the gastrointestinal tract. Although rare, AVMs may cause gastrointestinal bleedings and occur more commonly in the small intestine, but may also be found in the large intestine. Histopathologically, AVMs are congestion hematomas composed of an inflow artery feeder, an abnormal blood vessel assembly nidus, and an outflow vein drainer, which are not confined to the mucosa or submucosa but can infiltrate the serosa. A 69-year-old Asian man had a history of cerebral infection approximately 1 year prior and had been taking antiplatelet medication. Over the last 3 months, he had persistent hematochezia, and his blood test showed a progression of anemia from hemoglobin 15 to 7.4. He was referred to our hospital. Contrast-enhanced CT scan revealed accumulation of abnormal vessels in splenic flexure of the descending colon. 3D reconstruction of the CECT showed that blood flow to the region was supplied from the left colic artery and the left colic vein. Colonoscopy revealed a pulsating submucosal tumor-like region in the descending colon that was 40 cm from the anal bulge. A scar of the region was obtained via biopsy. In the first colonoscopy, the possibility of a hemorrhage submucosal tumor was considered, and a biopsy was performed. The usefulness of the gel immersion techniques using a transparent gel with appropriate viscosity, viscoclear, for securing the visual field to identify bleeding site and EUS has recently been reported. Therefore, we injected viscoclear to maintain a clear visual field during endoscopic examination, identify the region, and perform EUS. After gel injection, the pulsating region was observed clearly in the space occupied by the gel. We used a sliding tool, STCB1 Olympus, which was a sprint device preloaded over the scope for preventing the rear-loop formation of sigmoid colon. A forward-oblique viewing radial echo endoscope GFUE 290 Olympus was successfully passed through the lumen of the tube to the descending colon. Color Doppler ultrasonography conducted directly under the region identified a vessel that penetrated the muscle layer and entered the submucosa. The vessel penetrated the colon wall from the 6 o'clock direction and ran along the inside of the wall and penetrated the muscle layer from the 4 o'clock direction. Therefore, the 4 o'clock to 6 o'clock direction was considered as the nidus. The 6 o'clock vessel traveled toward the 8 and 9 o'clock positions and was a very large vessel. Therefore, we considered this to be a drainer. The 3 o'clock vessel exited the nidus, penetrated the muscle layer, and ascended in the 12 o'clock direction. Therefore, based on the diameter of the vessel, we thought that this was a feeder. Colonoscopy and EUS confirmed that there was a nidus of 70 mm in the wall of the gastrointestinal tract, submucosa, beyond the muscle layer. Then we thought that bleeding could not be controlled by endoscopic treatment, and vascular evaluation was selected. Additionally, EUS was necessary to rule out submucosal tumor intervened with the AVM. Even high-quality CECT 3D reconstruction and angiography cannot detect nidus location in the colonic wall. Furthermore, even if a submucosal tumor was intervened with the AVM, high-quality CECT 3D reconstruction and angiography cannot detect it. Only color Doppler endoscopic ultrasonography can detect these regions and is very useful for determining the appropriate therapy. Angiography of the inferior mesenteric artery showed vascular hyperplasia and nidus. The drainage was thicker than the feeder and coiled nidus was visible, similar to the EUS findings. We performed coiled embolization of the AVMs. 2 months post-operatively, endoscopy showed that the AVMs had shrunk with evidence of scarring. Furthermore, the hematochezia had disappeared and hemoglobin level improved to 14 grams per deciliter. Identifying each component by EUS can diagnose the localization and the diameter of the nidus in chronic wall, which are important factors in determining the indication for endoscopic treatment and the choice of embolization or surgery. Color Doppler endoscopic ultrasonography is useful for evaluating gastrointestinal involvement in AVMs of the colon and selecting treatment methods.